is a collaboration with Dr. Gore's work, and are hoping to extend it further into the future. So when faced with making a decision, we've become more and more comfortable using data, using graphs, analytics, statistics as tools to help guide our decision making. When we're thinking about what stocks to invest in, we look at the stock's prior behavior and try and project how we're going to make the most money. Similarly, when we set up our fantasy football league, we think about the players' prior behavior over the last year and try and project how many points we're going to get each week. But for some reason, when we make decisions about the things that matter the most to us, we don't use this kind of information. So the question is, how can we be better about making decisions that come to our own health? So let's take an example of a question that every single prostate cancer patient will someday face. What is the right treatment for me? In the current environment, you'll definitely talk about it with your doctor. You'll probably talk to a loved one, and ideally someone who's a survivor themselves or a support group peer. But in the end, we're facing some really difficult decisions. And is 1, 2, 3, 10 data points enough to really make a confident decision? So the IPCR Empower project is an effort to harness some of that information that's out there. Every year, over 5,000 men are diagnosed with prostate cancer in Washington state alone. That's 5,000 data points that we can harness and use to make better decisions. So our question is really asking, what if you could ask every single man in Washington state for advice about what decisions to make? So that's really what Empower is. We've designed an online web portal where you log in and you answer a few questions in a survey format. We ask you things about whether you've had treatment and what kind of treatment you've had. We ask you about your family history of prostate cancer to help us dive into some of that genetic risk that we've talked about earlier this morning. We also ask you things like the quality of life you've experienced. What are your side effects? Are you satisfied with the care that you received? Once we collect this data, we can start to see global trends. We can look at bucketing men into the kinds of treatments that they've had, and we can start to really use that information to layer on more complex issues. So we can start to layer on the side effects that men experience, and to what severity, what frequency. We can also layer on other factors such as the survival rates that we're seeing, the exercise and nutrition patterns that these men have. And once we have this information, we can do more with it. Once we know what the population is looking like, we can design interventions. We can partner with our researchers and clinicians here and design exercise interventions, as we talked about earlier, and maybe track those with fitness bands or nutrition interventions and see. We can start to actually measure how we're able to improve the population at a statewide level. So really, the vision of Empower is to provide men an opportunity to have access to the data points that'll help drive the decisions that they make, to have access to more valuable information than they have today. We also want to use Empower as a tool to engage men and to think about how they can be better about their care, and also to help them participate in prevention interventions that might really help change the face of prostate cancer in the future. We also want to partner with clinicians and researchers to give them access to this population data. As John Gore said, doctors think they know what's bothering prostate cancer patients, but maybe they don't. And also we want to be able to connect researchers and patients to think about participating in prevention trials in the future. So our last connection is with prostate cancer advocacy. We've partnered with the Washington State Prostate Cancer Coalition, which is an organization whose main goal is to increase public awareness and visibility of prostate cancer. They're excited to use the information that we collect to fight for prostate cancer needs and resources at the local, the state, and even the national level, to keep grant funding coming in, to make sure that your voices are being heard. So we're currently building the website. What you saw are actual mock-ups of what we've been building right now, and we hope to launch this summer. So I'd like to end with one question and one ask of each one of you in the audience today. When you get invited to participate, please stop and take 10 minutes. It's just 10 minutes of your time, and fill out the survey. We want to be able to make sure that your story, your experiences, and your data are able to empower the men of Washington State to make better decisions about their care in the future. Thank you.
Okay. Great. So we've got our next Q&A period here for about 15 minutes. We're spot on time. I want to thank all three of the presenters. So I'll start with the first question that I already got, which is a burning question for many individuals that would love to avoid biopsies, and that is the role of imaging. So this is for Dr. Lin. There's been pretty remarkable advances in technologies for imaging the prostate, particularly MRI scans, 3T MRI, and now kind of co-registration with ultrasound, et cetera. So Dr. Lin, what do you think the role right now is for imaging, the state-of-the-art imaging, 3T MRI, and maybe MR spectroscopy in active surveillance in particular, maybe following over time, but just overall in disease management and diagnosis?
MRI is, I think the easy answer is that it's not quite ready for prime time. And in fact, it's not on any guidelines. I can show you the exact quote from the NCCN and others saying that MRI is not considered standard of care. However, I do think, and I think it's an emerging technology, and I think it will eventually. There are 2 or 3 studies that are ongoing right now. One in Europe that's a several hundred patient trial that will really define the utility of MRI. We do have an MRI fusion with ultrasound program at the university. We're the only one in town that's doing that. Now we're just launching that. And so I think we believe in it. If you look where we're going, we don't really go forward with any programs until we really think the data support it. I do think that at this point in time, it's considered investigational and active surveillance. For men that have had a previous biopsy that has been negative, that's where it seems to be of greatest benefit. The MRI seems to be of greatest benefit in perhaps detecting lesions that were missed. So there was a question earlier about that, and I was sitting next to a clinician, and we said perhaps that person should get an MRI to make sure there's not an anterior lesion that's missed. So I think the short answer is it's not standard of care, and the future is that it's coming, I think, very soon.
Follow-up question? Yeah. Can you just get that mic, and then we'll pass it back.
I recently got an MRI, but I was not given an ultrasound. What is the importance and benefit of doing that co-registration?
Yeah, great question. The benefit is only if there's actually a lesion. So here's I'll tell you a little bit longer answer is that if I took 100 men on active surveillance and I did an MRI on them, at least 50 would have a completely normal MRI. So clearly MRI doesn't pick up all cancers, all right? At the same time, if I cherry-picked a bunch of MRIs that had lesions on them, most of them would be higher grade lesions. So MRI is not perfect. If there's no lesion on MRI, there's no reason to do an ultrasound fusion.
But the role of the fusion would be to be able to biopsy that.
To be able to biopsy that specific area.
Yeah, question.
This question is for Dr. Lin. What exactly is the value of a digital exam? Because from the colon side, you can only see half of the sphere, and the other half of the sphere is on the inside.
Yeah, so a couple answers to that. The side of the sphere, the side of the prostate that's palpable during a digital exam is the side that 85 to 90% of the cancer forms. So we are palpating the most significant side of that sphere. The role of the DRE, I think, is going down. We used to, if you look at the European data, and particularly in the 80s and 70s, that's how we diagnose prostate cancer. With PSA now, 80+% of prostate cancer that's diagnosed now has a completely normal digital exam. PSA has really changed the way that we diagnose and changed the way we even think about digital rectal examinations.
It still does occasionally pick up rectal cancers. So, I mean, there's other reasons to do the DRE other than prostate, and you can get a fecal sample to look for fecal occult blood. I mean, so it's not completely useless, but for prostate cancer, clearly.
And Dr. Lynn, you'd agree that if you're going to stage them, that is, once you have cancer and you're trying to figure out how bad it is, the DRE is...
Yeah, but all men get a DRE with the biopsy, so we kind of know that already. But it is something that we look at, actually. Someone gets a PSA, it does promote a biopsy. Usually during the biopsy, we know their DRE. So if there's a nodule or if there's something very obviously firm on the DRE, it does help staging. Yeah.
So a question for Dr. Gore. There's a, after surgery or radiation, there is a fairly high degree of impotence or loss of sexual function. Some men actually get erections at night, so not when they're, at the time when they're necessarily intending to use it, so to speak. What would be the relationship if you actually did get erections at night? Does that predict that you actually may regain some sexual function?
Yeah, I mean, I think that's a great sign that the machinery is working. And so, I think that, I don't know that anyone has actually explicitly looked at the prognosis of, long-term recovery of sexual function if you start having nocturnal erections, but you don't have as high-quality erections when you're trying to have them on demand, like you're trying to have a sexual encounter. But that's just a great sign that the nervous innervation of the penis, the blood flow to the penis, that everything is conspiring to work. So I would say that's a positive thing.
Actually, Pat Walsh did a study many years ago, and it was not a complete study, but it did suggest that nocturnal erections can easily disappear in men who are still very much potent after the surgery. So I wouldn't, if you're not having erections at night, it's not, you don't necessarily have to get out the gun.
The flip side, yeah.
I'd like to ask Dr. Gore a question. And I was reminded of somebody told me, just because you made the majors doesn't mean you bat 300. So can you tell me if you know of any data or what you think about the relationship between where the treatment is given or who gives it? Is it a general urologist or medical oncologist, somebody fellowship trained, somebody who does just that sort of thing? Do you have any data or any opinion on that?
So there's a fairly robust body of evidence of something that we call volume outcomes relationships, and it's this idea that the more you do, the better you are. So in general, we know that in higher risk surgeries like bypass surgery, removal of the esophagus for esophageal cancer, removal of the pancreas for pancreas cancer, that going to see a surgeon that does more of those, you're more likely to have a better outcome. Now we know in prostate cancer that's also true, that if you go to a prostate cancer surgeon who does more surgery, you're less likely to have some of the side effects of prostate cancer surgery. You're less likely to have scarring where the bladder was sewn to the urethra and some other outcomes. We wanted to do a study using capture data, which is registry data that's coordinated out of UCSF, to look at volume outcomes relationships and quality of life outcomes, but that was felt to be a little too charged of a question. But I would guess that would hold up as well. So, I mean, I think one thing that we used to always hear was that, good surgery is better than bad radiation and good radiation is better than bad surgery. And so you just want to go to a doctor that treats a lot. Now, there is some evidence that going to a comprehensive cancer center is also associated with better cancer-specific outcomes, but that's not as convincing as just going to someone that does a lot of something.
Question back there.
I was wondering about prostate check of the punches, as far as if you did have prostate cancer and you're having the biopsies, 16, isn't that going to spread the cancer potentially?
It's a great question. And this is a worry, you're placing a needle through the rectum into the prostate multiple times. We've never seen the needle track or rectal recurrences of prostate cancer. We've also not seen there to be increased number of recurrences in men who have had more biopsies. So we've looked at that too. As some men, particularly on active surveillance, have had 6, 7, 8, 9 biopsies, and there does not appear to be higher rates of recurrence with men that have had more biopsies, suggesting to us that there probably is not a spread just by jabbing the prostate. We here at our center, we couldn't get into it today, I don't think anyone was talking about disseminated tumor cells, but we've seen that some of the cells that might escape the prostate happen very early anyway, even before biopsy. So there are a wealth of data showing that these cells might circulate, get cleared by your immune system or otherwise, but we haven't seen any detrimental effect of biopsy itselove.
I guess I was hoping for a
question.
cauterizing needle.
Oh, cauterizing needle, yeah, exactly.
Maybe a word about focal therapy. Do you want to open that one up? And then Paul, I think there's some questions in the back there.
Just focal therapy in brief. So we do cryotherapy here. We usually do it in the setting of recurrent disease after radiation. There are others in the community now. I showed you the NCCN guidelines for a reason too. You don't see cryotherapy on there. You don't see HIFU, heating the prostate, freezing the prostate, hormonal therapy, very cyberknife, stereotactic radiation. It's not up there. It's not up there for a reason because the data don't support it. In the recurrent setting, which we didn't have a chance to get into, we have been doing more focal therapy. And so instead of ablating the whole prostate, just maybe a portion where the prostate cancer is, and we're doing mapping studies and so forth. So,
there's a question way in the back. Yeah.
Yeah, I was interested in the difference in the patient's perception and the physician's perceptions of side effects and some of the things that you're doing to prevent that, but I'm wondering if we're looking at the teaching learning and the fact that when we're talking about incontinence and erectile dysfunction, you're talking in the context of cancer and what treatment am I going to have. And the nurse in me is wondering if there isn't a better way to educate our patients pre that decision, because speaking to a layperson about incontinence and erectile dysfunction and saying, well, it'll maybe get better, it may not, but they're more focused on the cancer. And I think that goes across the spectrum of all cancers, not just prostate cancer. But I wonder if that's being addressed as an educational process.
Yeah, that's a great question. So there's some work out of a multi-center effort that takes place almost all in universities called ProsQA, where they've looked at a couple things. Number one, and I didn't mention this, they looked at caregivers and spouses. So another thing that we've learned from that is that maybe patient report overestimates how they're doing, and that we would look at what their spouses say, that they might report that their outcomes are a little different. And that's something that we're going to do in November as well. We're going to measure caregivers and spouses as well. But they've also looked at expectations. And so one thing that we're very interested in is, because no one's really done this, is if you present someone with sort of their expectations for the future on a more personalized level, if you can help them understand in a more realistic way what their expectations are for after treatment. Now, that doesn't get at what you're talking about in terms of counseling, but it may help influence also the conversation that either the nurse has with the patient or the doctor has with the patient about generating really appropriate expectations for the future. I agree with you, that's really important.
Got a question back here?
Out of all of the encouraging news about the recent advances and everything we've heard this morning, is there a plan to get this kind of information, once it's recognized as being pretty standard care, out to the medical community in general? It seems like it sometimes takes a long time to get out to your maybe your smaller town urologist and some of the folks who don't have access to the kind of information we have here. Is there an overall plan to get this out to the medical community?
So I was just going to make one quick comment and then hand it over to Nola. But that gets at this concept of what we call implementation and dissemination. The idea that we've learned what works, we've learned what's good, we've learned what we can do here locally to make prostate cancer care or prostate cancer treatment better. But now we don't want to just exclude everyone who doesn't get their care here from that. We want to disseminate it to our urological community. And so we do some work locally with quality improvement through other hospitals that are participating in a collaborative to try to do that, to try to disseminate some of those sort of best practices. And we do a lot of outreach. But you know, we're still learning how best to make that happen, and I think Empower is going to help with that.
Yeah, so one of the exciting parts of the Empower project, but also the challenge, is that we really want to be Washington State. We want to be capturing everyone's experience and sharing that information with practitioners across the state as well. So we're going to be working on a rollout plan to make sure that our information is capturing the patient experiences from the most rural edges of Washington, but also engaging the urologists as well and giving them an incentive to use the data and learn about how they might be able to transform their care no matter where they are.
Good question here.
Thank you. Well, I have 2 points, if I may. Number one is that my urologist, when I was diagnosed with prostate cancer, made me, my wife, and my 2 sons read the book, A Family Guide to Prostate Cancer by Dr. Sheldon Marks. And before I went to surgery and all, I knew exactly what the side effects are, what can happen. It's a very informative book. It's called Prostate Cancer, Family Guide by Dr. Sheldon Marks. In answer to the question the lady had before. Now, a question for Nola is that last year you mentioned something about a workshop which was in plan for prostate cancer prevention. Now, what's the fate of that workshop? Is it going to happen in 2015, or is it going to go to 2016, or what? Thank you.
We definitely want to make that, it's a clinic that we're planning to have, a prostate cancer prevention clinic to look at family members of those with prostate cancer, as well as those that have prostate cancer. We're doing all of our due diligence to do all of the research and make sure that we're getting the expertise from people locally as well as from around the world to make sure that our recommendations are solid and consistent, because this is kind of a new idea. So we're taking some time to make sure that we are prepared and ready to launch, and we're hoping to launch this year. But I'll be letting you all know when that happens.
Last question before lunch. It's a combo question for Dr. Lin. So how fine is the line between 3+3, 4+3 Gleason grading and recommendations for active surveillance and risk? And the second kind of parallel, if somebody has a very, very large prostate with prostate cancer in it, perhaps in low grade, is that person still appropriate for active surveillance or more aggressive treatment? In other words, could you be missing something?
Yeah, so the first question is about the difference between grading. Well, the joke, one of my colleagues, who's a pathologist, by the way, said, yeah, if you get 2 pathologists in the room, you're going to get 3 opinions. And my father's a pathologist, so I can make that joke. But it is true. There is a fine line between Gleason 3+3 and 3+4, and we did a study which I didn't have a chance to show you, where we took 100 consecutive men with prostate cancer of low grade, and we gave them to 7 specialists around the country at academic centers, and we said, grade them. 75 out of the 100 they graded exactly the same, but 25 they didn't. So 1 in 4 there was significant differences. There were some that said it was a 6, and some 7, some 8. And so there are more novel tests that are coming out now. There also was just a meeting about 2 weeks ago in Boston of the pathologists that it was an international group of pathologists that will probably change the grading in some way. Instead of having this 6, 7, 8, 9, 10, they'll probably have a 1 through 5. So it's going to change quite a bit. I think a Roman numeral 1 through 5. But 3+4, there is a bit of a difference. Now, 3+4 we also think, so mostly 3, but a little bit of pattern 4, might be appropriate for active surveillance. And I didn't get into this here, but there are many centers across the world, and this country as well, saying maybe we should watch those men as well. So as far as the big prostate question goes, I think there's been some pretty good data showing that large prostates that find a little bit of cancer in them actually do better. It's not their PSA is going up probably because of the prostate. Get a biopsy, they find a little bit of prostate cancer, but that's probably all that they have. Smaller prostates, seemingly there is some data showing that they might do a little bit worse.
So you wouldn't necessarily just jump into surgery simply because
just
you have
because
a
big
prostate.
prostate.
Yeah. Wonderful. So that ends the morning session. We've got lunch out here. Grab these folks if you have additional questions. We're going to start spot on at 12:30.